All right, welcome. GYN sonography. What's the point? Why are we doing this? Well, I think the reason for a GYN ultrasound is two parts basically. One, give a pelvic snapshot, which I'll explain, and two is to answer a clinical question. We know as OBGYN providers that the clinician who ordered the exam is asking a question, and hopefully we will be able to yield some helpful information in answering that question. That said, why us? Well, we already do some GYN on a regular basis anyway. Ectopic pregnancies are sometimes sent to us from triage. Molar pregnancies are sent to us. Retained products of pregnancy, also sent from triage. And then adnexal masses in pregnancy. That's a big one for us, where we find incidental findings of adnexal masses in pregnancy, and we should be able to handle those really well. Now, in addition to having already done some, the point is that we are OBGYNs. The providers are OBGYNs. Before doing maternal fetal medicine, there was 4 years of OBGYN residency. So we have some idea of what the clinician is looking for. Now, the reason I think we have at least a potential to do a better job than the radiologists is that really very few of them are actually interested in the topic. It's just part of the service they provide. They're not that interested in it. And for that reason, I think we can do a pretty good job. And we certainly have the potential to do a better job at the stuff we're already doing. All right, again, along the lines of why us? Well, in addition to the OBGYN physicians, our sonographers are somewhat unique in that they are very comfortable with obstetrics and with gynecology patients. They're very comfortable with endovaginal ultrasound. Our sonographers are familiar with pelvic anatomy, and patients can pick up on that. When they can tell they can tell when a sonographer is confident and competent. Now, let's talk a little bit about the pelvic snapshot. This is a concept I have that I thought it would be important to give the clinician a pelvic snapshot of what the pelvis looks like at that moment. When you go to the dentist has this record. It used to be a little piece of paper on the bedside table there. Now it's a digital representation. But basically, what it looks like is this graphic representation of someone's mouth and the teeth that are in it. Explains which ones are missing, which ones are there, which ones have fillings, which ones have crowns, the whole deal. And generally, when your dentist walks into the room, you can tell that the dentist is looking at this, figuring out what things are supposed to look like, then they turn around and look in your mouth and compare the two. Well, this pelvic snapshot, just like this snapshot that the dentist looks at each time, I think is important because, well, the chance of your clinician remembering what the exam looked like a year or two ago seems like a long shot to me. Certainly, they do make notes and they try to describe it in their words, but sometimes they're not the provider that saw the patient last time, so the report is not clear. So what I'd like to do is provide some accurate pelvic snapshot they can look at and say, oh, well, at least last time it looked like this. I think this is particularly important because even though the clinician performs a physical examination, it's not that easy to do. They do this bimanual examination where there's one vaginal hand on the cervix and then there's an abdominal hand, and the uterus is felt between the two hands. Same way with the adnexa. And from those two hands, one abdominal, one vaginally, They're trying to figure out the size of the uterus, the orientation of the uterus, the size of the ovaries, and assessment of other characteristics like mobility and pain. Now, this bimanual exam can be limited, and I feel like over the last few decades, it's become increasingly difficult as our patients get larger. And you can see with a lot of visceral or subcutaneous fat, you can see there the distance between the skin and the uterus is quite a long distance. So if you're trying to feel the pelvic contents between two hands, if there's a lot of stuff in between, it can be really hard to figure all this stuff out. There are also other reasons a bimanual exam can be limited. Pain is one of them. So if a patient's presenting for pain, and you want to do a good exam to figure out why she has pain, it's also one of the hardest times to do a very accurate pelvic exam. Sometimes at the extremes of age, very young or very old, the exam gets a little more challenging for a number of reasons. But even in the best of cases, a thin, comfortable patient, it still can be difficult to determine specific things like cavity length, axis, and changes in volume that are somewhat subtle. So this idea of a pelvic snapshot is that the patient, if she's had a previous ultrasound or snapshot, the clinician can review the pelvis before the exam and have some idea of the pelvis in this qualitative and quantitative, because we'll have had measurements there, idea of what's in the pelvis. And as I said earlier, the clinicians often refer to their previous exams, but sometimes the previous exam wasn't that hot either, or they were done by somebody else. So the goal is to provide some visual and verbal description of the pelvis, meaning we're going to put in specific language that qualitatively describes the pelvis, but also numbers that quantitatively discuss the dimensions of pelvic contents. And then we would also like to provide a visual description. That part would be unique to us because that's not typical for a radiology to report to include pictures of the pelvic exam. All right, well, step one, when we're doing any GYN scan, is we're going to do this pelvic snapshot, meaning we're going to go through in a systematic fashion and describe the pelvis. So the first thing we're going to talk about is the uterine axis. In other words, the axis of the uterine corpus, the top part of the uterus, compared to not only the cervix, but also to the vagina and axis of the patient herself. So version refers to the axis and flexion refers to the orientation of the corpus and the cervix. So version, basically, it's relationship to the vaginal and abdominal axis, and flexion, corpus and uterine cervix axes. So just to review, the top part of the uterus is the uterine corpus and the bottom part is the uterine cervix. So we tend to talk about the uterus and the cervix as if they're separate organs, but technically the uterus includes the cervix. So the top part, the body, the bottom part, the cervix. Cervix means neck. All right. Now, knowing the anatomy is very helpful in understanding what it can look like in there. Generally, you've got this uterus, and right where the cervix and corpus meet is where the uterine arteries come in. That's also the same exact place where the cardinal ligaments come. So there's these ligaments that come in from the side, and the vessels are within the cardinal ligaments. Probably an easier way to think of it is if you've got a wine glass and the bottom is the cervix, the top is the actual glass itself holding the contents, the cardinal ligaments would attach to the stem. Some more anatomical terms here to talk about. A fornix. A fornix is an arched or vaulted structure, or a fold. So, when we're talking about the vaginal fornices, what we're talking about is the little pocket in the front, back, and on either side of the cervix. At least the cervix that is in the vagina. Half of the cervix is above the vagina, and half of it is in the vagina. And the little pockets on the sides are the fornices. And you can see on the far right there a probe that has entered the posterior fornix. The way it's supposed to be is the anterior fornix almost all the time that we're doing ultrasound. So the picture in the middle is a probe in the anterior fornix, and it basically gives you a nice clear shot of the whole anteverted uterus there. The one on the right is one where it has slipped right past the anterior fornix into the posterior fornix, and then the ultrasound picture right above it is basically a picture of the rectum and the rectal contents, because you went on past into the posterior fornix. Well, if we're talking about version and axis, we need to know what the vaginal axis is, we need to know what the cervical axis is, and the uterine axis, which is the top part. So, when you're doing the vaginal axis, we've got abdominal. You can tell that that footprint belongs to a abdominal probe. And if you're basically with an abdominal probe, it's you can tell there that the actual axis of the vagina is about 45-degree angle. It's not the same as her axis, like her spine. It's about 45 degrees on the example at the left, but the one on the right is almost straight to the floor. It's almost perpendicular to her spine or her abdominal axis. Now, whenever you're trying to figure out what the vaginal axis is, when you put the vaginal probe, it goes into the anterior fornix and stops right at the anterior wall, like that upper left-hand picture. Now, although the vaginal ultrasound has a slight offset of angle, it's generally kind of straight on down the line. It's pretty close. So when the probe goes in, you basically are in the anterior fornix, you hit the anterior wall of this anteverted uterus, and it gives you that. You can kind of say, okay, well, the vaginal axis must be what that red line is, straight on down the line of a vaginal probe. Then, in your mind, kind of slide it over to the external os, because that will be helpful in determining version and flexion. So slide it over in your mind over to the side. So now you can tell it's not lined up with the probe, but it is lined up with the external os. All right. Now, the cervical axis is basically going down to the cervix and trying to best put that line on that accounts for most of the cervix. The cervix is often curved, so it won't be in there perfectly, but you do your best to kind of put it there. So you can see 3 examples of the cervical axis. The first one is an anteverted one, uterus, and there's the cervical axis. Next one's a retroverted one, cervical axis, and then the last one is an abdominal view of the cervical axis. And then the last thing you want to figure out is the angle or the axis of the corpus, the upper part. Same way with the cervix, where you try to match it up the best you can, even though it's curved. You kind of put that right on there in that anteverted one. Then the next one is also anteverted. You put that on there. And the last one over on the right is a good example of how you do it when the whole thing's curved. Well, you can kind of go to the internal os and the top of the fundus and then just put the axis between those two. That's what happens in that picture. All right. Whenever we're talking about the axis of the uterus, for the most part, we're talking about the cervical axis as compared to the vaginal axis. All right, so if you put the vaginal axis in with that red line, which is you in your imagination just sliding that footprint over to the external os, and then you think of where the cervical os is, cervical axis is, and then you get that angle there. Same way with the retroverted, you put the vaginal axis, the red line, right at the external os, do your best to put a cervical axis in, and then you can figure out the axis. So the first one, it's in front of that red line, so it's anteverted, and in the second one, it is behind it, so it is retroverted. Now, in general, if you're doing a transvaginal ultrasound, the probe will be in the anterior fornix. And if it is in the anterior fornix, it's generally an anteverted uterus. Same way now if you're in the posterior fornix and you see the uterus, that means that it is a retroverted uterus. Here's a rare exception where it's a mid position and the tip of the probe basically is sitting there in the external os, actually dilating it a little bit, but it's straight on through. The vaginal axis and the cervical axis are the same, so that would be mid position. All right, flexion, now you need to know what the corpus axis is. And the corpus axis, we've got here in the green line, and if the cervical axis and the corpus axis have that, anterior angle, it is antiflexed. And if the cervical axis and the corpus axis do not have an angle, there is no flexion. So you don't have to describe the flexion. You would just say it's anteverted. And then the one on the far right, you've got your retroflexed uterus. Why is it important that we make a point of that? Well, many procedures that GYN physicians do involve introducing an instrument into the uterus. And most of the time, whether it's an endometrial biopsy or an IUCD insertion, it's done blindly, at least blindly, meaning without ultrasound. And when you do a procedure blindly, you're basing it on the assumption of the anatomy. And since anteverted, antiflexed is the most common, most of the time a procedure is done, it's done based on thinking that's the position. And you can see that there's the things over there on the right, those instruments, those are dilators. Those are the things that dilate a cervix. They start off little and they get bigger. But they have a curve in them so that you can follow the curve of the cervical corpus angle, typically anteflexion, if that's what you think it is. And the picture at the left is an example of a sharp curette for a D&C where they underestimated how much flexion there was and just kind of had a gentle curve to their instrument, which wasn't enough. So it just went right through the back and there was perforation of the uterus. All right. So typically, if you don't realize that the uterus is sharply anteverted, you can do a posterior perforation. Similarly, if you think that the flexion is anteverted and you put the curette through the anterior wall, you'll result in perforation. Now let's talk a little bit about cavity length. Cavity length, knowing the distance between the external os and the fundal portion of the cavity is very important when you're introducing an instrument, because if you underestimate or overestimate the length of the cavity, you can perforate right through the fundus. So this is an example of a endometrial biopsy that they thought that the uterine cavity was bigger than it really was, and they resulted in a fundal perforation. Here's some other examples where knowing what the cavity length is could be important. One of them is putting in an IUCD. If you put it in too far, you go right out the top of the uterus, fundal perforation, and actually device insertion in the myometrium or beyond. And then the one at the right is where the instrument was not introduced far enough. Now, generally, when you do an IUCD insertion, it involves sounding the uterus, meaning you put in an object that has markings on it, it slides up to the top, you take note of that, oh, it's 8 centimeters or 7 centimeters, and then you prepare to insert your IUCD, but it's all based on the fact that you advance the instrument to 7 or 8 centimeters or whatever you determine the length to be, and then you deploy the device. Well, if you think it's, 10 centimeters, but it's really only 6, you may perforate. All right. Cavity length is measured from the external os to the fundus. And in that particular picture, we will type out the axis and flexion of the uterus. So here, it is called the cavity length. It is labeled as such. In the right-hand corner is where the cavity length is written. And then we add that text saying anteverted, anteflexed. And that's a very informative slide for them. They get in one picture the cavity length, the flexion, the version, and that's a lot of good information right there. That is one of the pictures that we will include in every report. Then we do a cavity length of the corpus only, meaning we exclude the cervical length. Now, how do you figure out the cervical length? Well, generally, the cervical glands have a different appearance to them, so it's usually obvious where the cervix ends. Sometimes it's not. You do your best. And that corpus only is its own picture that we include in every exam. And the reason we include that is that it has some clinical usefulness. For an example, an endometrial ablation, where the provider introduces an ablating type of instrument, whether it's cryo or electrocautery, but basically they need to know how long the corpus is. It's the corpus that gets ablated. And sometimes, if the cavity is too large, the example that we've been told by All About Women is if it's greater than 6.5 centimeters, the instrument that they have may not ablate the whole area, and they may consider her not a good candidate for ablation. All right. And then uterine volume only. Okay. We, in the past, have measured the entire thing. We measure the fundus to the external os. We do an anterior-posterior dimension, and then we get an axial view and go side to side. And we were cited by AIUM, and they said, no, that's not the way you measure the volume of the uterus. You only measure the corpus. So what we do is we do the measurements you can see down below in that picture, which is an AP dimension, and then a corpus sagittal shot from the internal os to the serous or the serosal surface of the fundus. And those give you 2 dimensions in the sagittal plane. And then you need to go in a separate one and get the axial measurement to get the 3 measurements that get plugged in, and then Viewpoint will calculate the uterine volume. All right. And then here's another measurement that's different than the previous ones, and we call it uterine length, where the external os and the serosal surface of the fundus, that distance is measured. And this was measured as a result of requests from referring doctors. And the reason they wanted it, because they wanted correlation. Because when you do a bimanual exam, those are the 2 points you feel. You feel the serosal surface of the fundus, and you feel the external os, the cervix. So they want that correlation. They find it very helpful. They check the patient. They kind of think, okay, it's 9 centimeters. Then they look and say, oh yeah, it really was. Or they can see how far off they are, but they like that kind of feedback. Another measurement that we put in, and again, we include this picture in every single report, is the intercornual distance, meaning the endometrial cavity from cornua to cornua. And the reason this is important is that when you're putting in an IUCD or you're doing an ablation, things where you want to know the shape and size of the cavity, it's a very important distance. And you can see that there's a couple different types of devices. There's one that's 32 millimeters, the Mirena. There's one that's 28 millimeters that you might use for a smaller intercornual distance. All right, here's a little special situation we're going to address while we're on this topic, which is post-cesarean version inflection. After a cesarean section, it is extremely common to go from anteverted, anteflexed to anteverted, retroflexed. So again, when you're talking about version, you are talking about the cervical axis related to the vaginal axis. So in this picture, the probe is in the anterior fornix and the cervical axis is anterior. So it is an anteverted uterus. But then you can see once you get to the internal os, it goes backwards instead of continuing forward. So this is anteverted retroflexed. The problem is a lot of times if you do a bimanual exam, it just feels anteverted. That's it. So you may think that it is what has always been, which is anteverted, anteflexed, but it's not. It is an acquired change of axis / version. And we also put this in the summary. There's a little drop down that says this whole point of an axis change following cesarean section. And obviously this is really important if you're doing a procedure and you think that the whole thing is curved forward and it's only curved forward until it hits the internal os and then goes backwards. That's a real setup for perforation through the anterior wall. Another thing to keep in mind is the cardinal ligaments, again, hold the stem of the wine glass. And sometimes it's like holding it with 2 of your fingers, which is a very unstable way to hold a wine glass, that you can see that the wine glass could flip over either way. Well, that kind of happens with a uterus a fair number of times, where there is a scan done abdominally, and all of our scans start with that first, this abdominal view. And the reason for that is 1, it kind of gives you an idea if it's anteverted or retroverted. And 2, the other thing is you're also making sure that there's not some abdominopelvic mass up and out of the range of the transvaginal. That's why you're doing this scout film or scout view above with the abdominal probe. This kind of tenuous arrangement of the wine glass between your thumb and forefinger can be reproduced with a vaginal probe, where you can see that it's anteverted and on abdominal, and then you go and put the probe in and suddenly it is flipped the other way. So first thing you do, just to make sure to see if this is what's going on, here's an example of one of our patients where we do the abdominal scan, and you can see that the uterus is touching the abdominal wall. So it certainly appears to be an anteverted uterus because it's touching the anterior abdominal wall. Then the transvaginal probe goes in the exact same patient 1 minute later, and suddenly it flips over. The probe basically caused that to happen. Well, if that happens, what you do is you just describe it in the summary, that it was anteverted by abdominal probe and endovaginal probe artificially rotated the uterus around the cardinal ligament. And the reason that's kind of important is sometimes the speculum, when they do their work, can do exactly the same thing. They think it's anteverted because they're bimanual exam. Then they stick in a speculum, and the whole thing flips over and is pointing the wrong direction. All right, so I did mention that there are certain pictures that are included in all of the reports, and here they are. This is basically 3 pages of a viewpoint report. The first one has all of the information, all the measurements. Then in bold, we have kind of the conclusion, and then you have those key images that are included in every report. We didn't talk about endometrial thickness today, but we will in the future. I just wanted to kind of get that out there, that there are standard ones that are in every one that you will check off to make sure that they're included. And that's it for today.